evening, everybody, and welcome to Getting to the Heart of Fertility, the Newlife IVF monthly webinar. Our sincere apologies. We do seem to have been having some technical difficulties, but I do hope that you're all seeing and hearing us now, and thank you for your patience and our apologies once again. The webinar was going beautifully at our end. We had a great presentation, and we'll just start back at the beginning again now. And so tonight we're going to be talking about polycystic ovaries, polycystic ovary syndrome, what it is, what it isn't, and talking in a bit more detail about the various fertility treatments that are available should you find yourself with PCO or PCOS. First, before we get to that, just a very quick, a few little housekeeping matters. We do love to answer questions from you during the webinar, or more importantly at the end of the webinar. But if you do fire them in by clicking on the Q&A button in the bottom of the Zoom meeting window, and we will get to them all at the end. We love having the questions, and they're our favourite part of the night, but we do keep them till the very end. So do please send them through at any time. From a COVID point of view, we do like to give you an update, and we are very confident that it's most unlikely that the coronavirus will affect our treatment from a lockdown point of view. We do recommend, though, that you don't get COVID, because that would lead to interruptions in your treatment. And with that in mind, we are highly recommending that you have the COVID vaccine. The COVID vaccine is fine to take during fertility treatment for both men and women, and right up until pregnancy. Once you are pregnant, we recommend you undergo an individual risk assessment. By that I mean you talk to your fertility specialist or your obstetrician about whether a COVID vaccine is recommended in your particular situation. It surprises some patients that we don't automatically say don't get it, because there are some particular situations where it would be very important to do so. So let's get started with the talk. So PCO and PCOS, what is the difference and how do we treat them? So what is a polycystic ovary? So at the end of the day, a polycystic ovary is an ultrasound finding. It's nothing more, it's nothing less. When we do ultrasounds to assess women who are having difficulties getting pregnant or have gynecological symptoms, we often do an internal ultrasound, and one of the things that happens during the internal ultrasound is the ultrasound person will have a thorough examination of your ovaries. And one of the things that they will do is go through your ovary and count the number of follicles within it. So if you look at this picture of an ovary here, this is the outline of the ovary, and within that ovary there's a number of little black circles, and they are called either cysts or follicles. We tend to call them follicles, but when we're talking about polycystic ovaries, we're talking about there being lots of these little cysts. Now, that can sometimes be a very good thing, because each of these follicles represents an immature egg that is available and ready right now for your body to use in order to help you get pregnant. The difficulty is that sometimes with polycystic ovaries, there's so many of these follicles, so many of these eggs around, that there's too much confusion within the ovary, and as a result of not being able to decide which egg is the one that is released, which egg is ovulated, nothing happens at all. So it can sometimes lead to that problem, but not always. So a polycystic ovary is very different to polycystic ovary syndrome, and I would say that if you have polycystic ovaries but not PCOS, that is undoubtedly a very good thing. So, and the reason it's a very good thing is it really does just represent an abundance of available eggs. So what is polycystic ovary syndrome? That is something completely different altogether. And what it usually consists of is frequently but not always polycystic ovaries as a finding on ultrasound. But for us to consider that you might have PCOS, we need there to be other things going on as well. And the other things that we are looking for in making the diagnosis is difficulties with ovulation. Now that might mean no ovulation at all, or it might mean that ovulation is happening very late in your cycle, or it might mean that ovulation is happening at weird and erratic times that make it difficult for you to get pregnant. The other thing we look at is your testosterone levels and whether you are showing signs of high testosterone. And that is sometimes confirmed based on your symptoms. So whether you might have difficulties with your skin, with pimples or acne, or whether you've got, whether you're challenged by excess hair growth on your face, chest or back, or by doing blood tests to check your testosterone levels. How is PCOS diagnosed? The most common way it's diagnosed is by Google, which, whilst it's the most common, may not be the most effective or the most accurate. And in my experience, we do find that lots of women are overdiagnosed with PCOS. So typing your symptoms into Google will always come up with results that are confirming the diagnosis. It will very seldom come up with web pages that deny the diagnosis, even though that may well be the most accurate analysis of what's going on. So I wouldn't reckon, I think Google's great. A lot of patients say to me, oh, I know I shouldn't doctor Google. Oh, I actually think it's quite a good source of information, but it's not a substitute for a good thorough assessment. The other situation that often leads to the overdiagnosis of PCOS is if you're being diagnosed by people who don't deal with a lot. So fertility specialists and experienced gynecologists are a little bit better at diagnosing PCOS than some GPs who don't always see a lot of this type of thing. So the way that fertility specialists will look at the diagnosis is firstly to consider your age. And one of the reasons that age is really important is that we know that young women, perhaps before age 20, 21, frequently have the symptoms of polycystic ovary syndrome, such as the menstrual irregularity. It really is quite common in that age group. Plus, we know that they very frequently would have lots and lots of ovarian follicles when they have an ultrasound. And the reason they have lots and lots of ovarian follicles is because at that age they have lots and lots of eggs. And anyone who's been to our previous webinars where we've talked about chances of getting pregnant and fertility, we always talk about how when you're young you have lots of eggs and it gradually declines with time. And one of the consequences of that is that a lot of young women in their teens, if they have an ultrasound, will meet the diagnostic criteria for polycystic ovaries. But remember what I said earlier, it's purely an ultrasound diagnosis. It's nothing to do with having the syndrome. So we are very mindful of age. The other thing we consider is that you might have polycystic ovary syndrome at an older age, but because of the natural decline in egg numbers, we might not actually see polycystic ovaries on ultrasound. So age really does play a factor. Period regularity is really important. We always ask patients very thoroughly what their cycle is like. Is it regular? Is it coming at the same time each month? Or is it coming late? Or indeed, is it coming really, really early? Is it coming at all? If you have very late periods or are not getting periods at all, that suggests you may not be ovulating or may not be ovulating reliably, and therefore makes us look for potential reasons, one of which is PCOS. The other thing we always ask about is, like I mentioned earlier, do you have difficulties with your skin? Do you have symptoms of high testosterone levels? Do you have blood test results that suggest you've got high testosterone levels? Blood tests are also really important because they help tell us with some degree of certainty whether you're ovulating or not. Those blood tests must be done on the right time of your cycle, and it really does vary a little bit from woman to woman as to what the right time is. So it's really important you do those blood tests at the right time. And finally, as we mentioned, the ultrasound is very important, although I do hasten to add that you don't have to have polycystic ovaries to have polycystic ovary syndrome, but it is an important and a common part of the diagnostic criteria. The other thing that's really important is to consider other diagnoses, because you could have thyroid dysfunction, you could have high levels of prolactin in your blood, and all of those things can lead to symptoms very similar to PCOS. And as a result, we always consider PCOS to be a diagnosis of exclusion. And by that, what we mean is we have to consider other potential diagnoses, exclude them before we can say this is definitely PCOS. So all all of the good fertility specialists will do that as part of your diagnostic workup. The importance of PCOS, it's very important from a fertility point of view, and Nicole's going to go over that in quite a lot of detail and also talk about the potential treatments. And obviously, if you're not ovulating, it's very hard to get pregnant. If you're ovulating but you don't know when you're ovulating, that's going to make it hard to get pregnant. There's lots and lots of things we can do about that, so stay tuned to hear about those. But some other things you might not be aware of are that if you've got PCOS and you're not ovulating reliably, or mostly if you're not ovulating at all, then we find that you are in danger of getting an abnormal thickening in the lining of your uterus, in the endometrium, that can become precancerous and even cancerous. So it's very important to know why your period's not coming, and if it is PCOS, sometimes we need to put steps in place to protect you from getting those terrible complications. Similarly, the imbalances in hormones within your ovary are related to insulin resistance. So insulin is a hormone that your body uses to control sugar levels. If your body doesn't recognise insulin as well, which we do see commonly in women with PCOS, you'll have generally higher sugar levels, which can lead to pre-diabetes or even diabetes itself. So all women with the diagnosis of PCOS should have a diabetes screen at the time of diagnosis, and probably every 2 to 3 years afterwards, depending on other potential risk factors, which would always be discussed with you together with your fertility specialist. Symptoms are very important because some of the symptoms of PCOS are very distressing. So having excessive facial hair, and having difficulties with your skin from a cosmetic point of view does upset most patients. And figuring out why that's happening, treating it with the appropriate medication if that's what you decide to do, or treating with the appropriate cosmetic treatments can make a big difference to individuals' well-being. As I mentioned, it's really important from a fertility point of view, getting the diagnosis of PCOS correct, because it is important that we treat the correct condition. So I'm going to hand over to Nicole Hope now, and she's going to go through the initial treatments and also some of the more advanced treatment options. Like I mentioned earlier, we do love your questions. Please do send them through at any time by clicking the Q&A button, and we'll absolutely be getting to them by the end of the evening. I'll be back soon.
So a lot of patients, when they see me, they ask, what can I do to get rid of polycystic ovarian syndrome? Is there something that I can be doing? Now, with PCOS, somewhere between 30 to 70% of women with polycystic ovarian syndrome will be overweight. And what we know is that if you are overweight, then losing weight might potentially reverse the PCOS. If you are a normal weight, in the healthy weight range, then losing weight is not going to help reverse the PCOS. But if you are overweight, we know that even small weight losses of 5 to 10 kilos or 5 to 10% off your weight can actually significantly increase the chance of you ovulating spontaneously. Even if you are not ovulating spontaneously, it might improve your chance of responding to the hormone medications that we give you, like ovulation induction medications such as letrozole or Clomid. So sometimes we see people might be on those tablets and they might be on the maximum dose, but they still don't ovulate. And when they lose weight, they suddenly will respond to those medications when they haven't worked before. My patients do ask, is there some sort of diet that I should be doing or particular foods that I should be eating? I think there's no magic diet, but I think it's a matter of experimenting and working out what works for you. I think most people who are overweight have probably tried many diets over their life, and they probably do know that there are some diets that work better for them. There is some evidence in mice that a Mediterranean type diet can be helpful, but whether or not that translates to humans is yet to be determined. But I think just common sense things, so reducing those refined sugars, reducing processed foods and saturated fats, more fruit and veggies, more lean meats, and you know, if you're already doing those things, maybe even just reducing your meal size. Exercise is important as well. I think if you're someone who has not really been an exerciser, it's important not to think you suddenly have to run a marathon or be running 10 kilometres every day. Definitely ease into it, and certainly I think diet is the main thing to be focusing on initially. But once you've got your diet under control, then focusing on exercise is a good thing to do. I would just start off slow by trying to just get out and walk regularly, and then you can build up exercise as tolerated. Generally, I would say you should be trying to exercise 3 to 4 times a week for 30 to 40 minutes. There are some other things you can do to help with exercise. Sometimes patients may be suggested to take metformin. Metformin is a diabetes drug. So sometimes people are on this already because they have diabetes or pre-diabetes or insulin resistance. In some women, metformin might also help with weight loss. However, there can also be side effects with metformin. So if you are keen on starting that medication, it's important you speak with your doctor about the side effects. And you also should always start taking that very slowly and ease into it to reduce the side effects. Finally, if you have tried every diet known to mankind and it still doesn't work for you, sometimes you may some sort of bariatric surgery like gastric bypass surgery, and certainly there are patients who seem to have really good weight loss with that and a return of their regular cycle and a reversal of the polycystic ovarian syndrome. So some people have tried weight loss and it's not working for them, or maybe they are normal weight to begin with and they don't need to lose weight, but they still have PCOS and they're still not ovulating regularly and they want to get pregnant. So often one of the first things we do is try a hormone tablet medication, and the two most common ones we try are letrozole and clomiphene. We are tending to use a bit more letrozole now than clomiphene. You take both of them in the same way, usually for a daily tablet for 5 days at the start of the cycle. And if you don't respond, then the dose can be increased for the next cycle if you don't ovulate. There is some growing evidence that there are better chances of ovulating with the letrozole. There are improved pregnancy rates and reduced miscarriage rates. And generally with the letrozole, you will mainly ovulate just one egg, so also potentially a lower risk of multiple pregnancy. So Clomid's fine, and we've all been using Clomid for years, and so if your doctor has prescribed Clomid, that's absolutely fine, but probably we are prescribing a bit more letrozole now. The good thing about letrozole and Clomid is they're tablets, they're easy to take, they're cheap, and there's not much monitoring required. You can get about 70% of women to ovulate on Clomid or letrozole, but not all of them will get pregnant. And so there are some women who just don't ovulate on the Clomid or letrozole, and there are some women who do ovulate but still don't get pregnant. And then there are people where we need to be considering other options. With both the letrozole and Clomid, you can get some side effects. I typically describe them as menopausal side effects. So you can get things like hot flushes, headaches, maybe a bit moody or teary. Most people cope with it really well, but every so often there is someone who might have really significant side effects with those tablets, and then again we need to consider other options. I've put down the bottom of the slide plus minus trigger. Some doctors like to give a trigger injection to induce ovulation. I don't usually do it. Ultimately, with PCOS, if someone has a follicle growing, usually it will actually ovulate itself. So I don't usually give the trigger, but I do know other colleagues do, and that's absolutely fine. So sometimes if you've tried the Clomid or letrozole and it hasn't worked, then the next step might be trying ovulation induction with FSH injections. So FSH stands for follicle stimulating hormone, and this hormone does exactly what its name says. It stimulates follicles to grow. And some of the common brands we use are Gonal-f or Puragon. This is a daily injection up until the time of ovulation. The good thing about the FSH injections is that we can modify the dose. So usually we'll start you off on one dose, and after a few days we'll do a blood test to check your hormone levels and see if there's any evidence of a follicle growing. And we can tell that because your estrogen hormone levels will start to increase. If your estrogen levels are not increasing, it probably means there's nothing growing, and then we need to adjust the dose and usually increase it. And so we keep doing this process every few days until we see the estrogen level rising, and then that tells us there's an egg growing. Usually then we are getting you to have a scan, and the main reason we want you to have a scan is to check how many follicles there are and how big they are. Unlike with the Clomid and the letrozole, there's a much higher chance of multiple eggs growing with the FSH injections. So you really need to be monitored closely because we don't want people to be having too many twins or triplets or quadruplets. So we do an ultrasound and then we usually give a trigger. We also usually give what we call luteal phase support, which means some extra hormone support in the second half of the cycle. Sometimes that can be with vaginal progesterone, or sometimes it can be with a few extra injections to support the ovulation process. With ovulation induction with FSH injections, there are some pros and cons. Despite the fact that it is a daily injection, people don't tend to get the menopause side effects that they get with the letrozole and the Clomid. There's a higher chance of ovulation, and because it's not lowering your estrogen levels, there are less potential negative effects on the cervical mucus and the endometrium. But it is a bit more expensive because the drugs themselves are more expensive and you need more monitoring and an ultrasound. It's also more time consuming because you do have to have some blood tests every few days and then a scan. As I mentioned, there is a higher risk of multiple pregnancy, but usually you're having a scan to assess whether you're at risk for that. But sometimes people do produce too many follicles and we do have to say, you can't go ahead this month. The risk of a multiple pregnancy is too high. So, IVF. IVF is also an option, and there are a few different reasons why you might move on to IVF. A lot of patients with PCOS come to see me and their doctors have told them that they'll never get pregnant naturally or at all. And the reality is we've already spoken about a few different pathways to get pregnant naturally, and when that doesn't work, we still have IVF as an option. So what are the reasons we might move to IVF? Well, maybe you tried the letrozole and the FSH injections and you're still not pregnant. Or sometimes I have some patients with PCOS who haven't responded to the letrozole. We try the hormone injections and it's impossible to get them to just make one egg. We've tried a few times and every time we get so many eggs growing, it's not safe to go ahead with trying naturally because the risk of multiple pregnancy is too high. Whereas with IVF, if we get a lot of eggs, we can take them all out and we can choose to just put back one at a time. So in actual fact, the risk of multiple pregnancy is actually less with IVF. Sometimes a woman can have polycystic ovarian syndrome and maybe her partner has some male factor infertility, or maybe she also has another problem like blocked tubes or endometriosis, which means her chance of conceiving naturally is also reduced. Sometimes I have patients with PCOS who are older and we decide to move to IVF because we know that at her age there will also be egg quality issues and it's time. Maybe we don't want to waste time with ovulation induction and we want to move straight to IVF. With IVF, the good news is that women who have polycystic ovaries or polycystic ovarian syndrome usually do really well and get a really good number of eggs. And usually the more eggs you get, the more embryos you get, And the more embryos you get, usually that is giving you some more chances to get pregnant from a single IVF cycle. However, the flip side of that is sometimes when women have a lot of eggs collected, they can be at risk of something called Ovarian Hyperstimulation Syndrome, or OHSS. So what is ovarian hyperstimulation? It's ovarian hyperstimulation syndrome. This is a condition that is due to fertility treatment. It causes fluid retention, particularly in the pelvis and abdomen, but it also causes women to be really dehydrated. In mild cases, women might have a little bit of bloating or abdominal discomfort and maybe some nausea. But in really severe cases, women can have significant abdominal bloating and distension, nausea and vomiting, shortness of breath. And in these very severe cases, they might actually be admitted to hospital, and that might be to try and manage their pain through a drip, or maybe drain off some of the fluid that's accumulated and try and replenish the fluid from the dehydration. And sometimes they need to be on blood thinner injections as well. So this is a really serious condition, and at Newlife IVF, one thing we are really mindful of is this OHSS. Nobody will thank you for getting hyperstimulation and ending up in hospital and feeling unwell. So we've got some really good strategies to try and prevent this. Unfortunately, there are no actual medications to treat hyperstimulation, although it will go away on its own. Mild cases just last a few days, but I have seen some severe cases that have lasted a few weeks, and they're the cases that we really want to avoid. So with ovarian hyperstimulation, we know the risk is increased by having a large number of eggs collected, but the hyperstimulation syndrome is triggered by HCG, which you may know as pregnancy hormone. We typically give you HCG as your trigger injection in IVF, and so you might know these medications by Ovidrel or Pregnal. So giving you an Ovidrel or Pregnal trigger can trigger this ovarian hyperstimulation syndrome. Because there is no treatment for OHSS, the best option is to try and prevent it. So when we scan women as part of their IVF cycle, if we can see that there are a lot of eggs growing or the estrogen hormone level is very high, then we know that potentially this person is going to be at risk of hyperstimulation syndrome. So sometimes we will suggest changing the trigger medication from an HCG to a non-HCG medication, and that could be something like Decapeptyl or Cinerol. Unfortunately, when you have a non-HCG medication, you can't have a fresh transfer. So in this situation, we would always aim to freeze all the embryos. Sometimes we have people who have had the HCG trigger already, and then after their egg collection, they start to develop symptoms of hyperstimulation. So they start to feel really bloated, maybe nauseated, shortness of breath. In those situations, what we would then do is not go ahead with the frozen transfer, because the other thing that makes pregnancy hormone is a pregnancy. So if we put back an embryo and you do get pregnant, often these are the women who can get really sick. So the main thing we want to do is change the trigger and freeze the embryos and not do a fresh transfer. A lot of women are quite stressed about that because obviously it is a delay in their treatment, but we can go ahead with a frozen transfer in the very next cycle. There's no need to delay treatment for months and months. The final thing people often ask me when they are actually pregnant, they'll say, look, I've been reading online and I've heard that women with PCOS have an increased risk of miscarriage. In actual fact, the increased risk in miscarriage is mainly due to having uncontrolled or poorly managed diabetes or being overweight. And so we know that unfortunately all women who are overweight do have an increased risk of miscarriage, and women who have poorly controlled diabetes also have an increased risk of miscarriage. If you have PCOS but you are a healthy weight and you don't have diabetes, then your risk of miscarriage is the same as any other woman your age. So it's not the PCOS that increases the risk, it's these associated conditions. So again, this brings us back to those lifestyle changes I spoke about at the start of my talk. It's really good to be having a healthy diet, managing your weight, and as Chris mentioned, getting assessed for diabetes and managing that appropriately, and that will put you in the best position for your pregnancy. So I'm now going to hand back over to Chris, who's going to finish off our talk, and then we will hopefully get some questions happening.
So Nicole doesn't deliver babies anymore, but she did once, and she taught me how to do it. So thanks, Nicole. That was 2005. So I've kept doing it. Nicole has stopped, very sadly, for all the patients. So later issues during the pregnancy, the PCOS alone, similar to what Nicole was just saying, in and of itself doesn't really cause any problems. It's the things that sometimes go with the PCOS that might be causing issues. And just like PCOS is associated with difficulty with processing sugar and maintaining sugar levels before pregnancy, it also causes higher levels of higher blood sugar levels, more insulin resistance during the pregnancy as well, and that does increase the chance that you will be diagnosed with gestational diabetes. Now, gestational diabetes is not the end of the world. It's really, really treatable, and the one bad thing about gestational diabetes is not diagnosing it and then not treating it. But if it's diagnosed accurately and well treated and you're looked after by a good obstetrician, then the outcomes are outstanding for gestational diabetes. Probably the biggest impact that gestational diabetes has on the pregnancy is that the timing of delivery is often just a little bit sooner. So rather than having a baby after 40 weeks, most obstetricians prefer that, depending on the severity that babies are born, somewhere between 38 and 39 or 39 and 40. Again, high BMI is an issue during pregnancy, and it leads to higher rates of placental dysfunction. So the placenta is the organ within your uterus that feeds the baby food and oxygen and water, and if that's not working as well, you can have a baby that's not as well fed, so that needs to be watched really, really closely. And what this creates is this opposing dynamic of having a placenta that's not always functioning particularly well, competing against high sugar levels, going to the baby and growing it a little bit bigger than it ought to be. So you've sort of got this competing interest of a baby that's got higher demands on a placenta that is closer to reaching its limits. So you do reach a mismatch between what the placenta can supply to the baby and what the baby actually needs. You reach that limit where the baby's going without a little bit earlier in the pregnancy. So balancing up how to investigate and how to monitor those things and how to manage them is a skill, and that's why you want to be looked after in a good hospital with good staff. So the take-home messages really that we wanted to make sure everyone was very familiar with is that polycystic ovaries on ultrasound does not mean you've got PCOS. It's great to have lots of eggs, and as Nicole was sort of talking about during fertility treatment, if you've got lots of eggs, then your outcomes are often going to be very, very good. We do have to be careful with things like hyperstimulation, but a much nicer problem to have too many eggs than to not have enough. The biggest though is, and Nicole touched on it as well, is we've all seen lots of patients who've been told you've got polycystic ovary syndrome, you'll never have a baby. Now, I'm never sure if that's what patients are actually told by doctors. If it is, I'm horrified, but it is unfortunately that's sometimes the message that is heard by patients. But I think hopefully tonight we've given you hope that if you do have PCOS, your chances of having baby are really, really good. It's just that you might need a little bit more help than the standard person. So we are going to go ahead and answer some questions now. So please keep sending your questions through. We've got a few through already. I'm going to get Nicole up to answer a few to start with, and I'll be back again shortly.
So the first question I have is, if I got pregnant first time with Clomid, should I change to letrozole this time around? And I would say, I think it depends on what your experience was like with Clomid first time around. I actually have a lot of patients who got pregnant on their first or second go of Clomid, and they had no side effects. They tolerated it really well, and they're very comfortable to take it again for the second pregnancy. But I think if it took a few goes, or you didn't always ovulate every time, or if you did have some side effects with the Clomid, then it's definitely worthwhile giving the letrozole a go for the second time round. And certainly any new patients that I have, I am usually suggesting to start on the letrozole straight away. The second question I have is, do I recommend any particular contraception for women with PCOS? So really, actually, any pill is good for PCOS. When I talk about pill, we have a couple of different types of pills, but we usually like what we call the combined pill, which has estrogen and progesterone. And this is really good for a few different reasons. It will keep the lining of the uterus really nice and thin, and that helps prevent the development of hyperplasia that Chris was talking about earlier. Also, the estrogen in the pill helps the liver to make a special hormone called sex hormone binding globulin, which will attach to your testosterone hormone and basically soak it up and stop the testosterone from having an effect. And so often when women have been on the pill, they will notice that their skin will improve, and they will have less hair growth. And if you're someone who experiences head hair loss, they will also notice regrowth of hair. So I think a combined pill with estrogen and progesterone is really good. If you are asking me for a specific brand, often I do suggest something which has a hormone in it called cyproterone, and you might know this by the brand names of Diane or Estelle. So cyproterone acts as the progesterone, but it may have some extra benefits with regards to the skin, the acne, and the hair problems that you might be having. Some women can't tolerate the pill, and maybe they can't tolerate the estrogen in the pill. And in those women, something like a Mirena IUD might be a really good idea, because that's going to keep the lining of the uterus really nice and thin and protected. It's not necessarily going to help with the skin and the hair, but at least it's going to help to prevent the development of hyperplasia. Did you want me to continue, Chris? One more? All right. So I have a question here. I have polycystic ovaries, but my blood test reports came all normal, including hormone tests. I have been told I have PCO and not PCOS. Does ovulation occur in this condition? So if you do have polycystic ovaries, but not PCOS, usually that does mean that you are ovulating. If you are not ovulating, then your periods will be irregular, and maybe you do actually have PCOS. So I think for you, Monica, I think I would say, are you having a regular period, and have you had some blood tests to confirm that you are ovulating? If you're having a regular cycle and you are ovulating and you just have polycystic ovaries diagnosed on ultrasound, then I would say you probably do just have polycystic ovaries and not actually the syndrome. So if you are having irregular periods, that may mean that it isn't just PCO. It may mean that it's PCOS, or as Chris mentioned, sometimes people have other conditions which can cause ovulation problems, not just PCOS. So maybe you have polycystic ovaries, but you might have trouble with your thyroid or prolactin hormone. And so that might be the reason why you may be having irregular periods. So I think Chris is coming to answer our last couple of questions, so I will hand over to him.
Thank you, Nicole. So the next question is, if you have PCOS and have used Clomid to conceive a pregnancy, when you are ready for another baby, do you recommend going straight back to your specialist for Clomid or to try naturally? So I would suggest that it would depend on what your cycle is like. So if you're having irregular cycles and therefore you're not ovulating in a reliable way, then I would recommend going back and getting straight back onto the Clomid, because it will make it much easier to conceive. However, if you're having nice regular periods and things seem to be a little bit different to what they were the first time, then there's nothing wrong with trying naturally for a little bit longer. Of course, the answer always depends on what is your age at the time, and the younger you are, the more time you have to try naturally without intervention. Whereas as you get older, we would usually encourage getting on with treatment a little bit sooner as a result. Quite a number of sort of questions or comments about the slides. I'm sorry about that. Hopefully we got to the bottom of those, and things are working much better now. Another question: does PCOS mean I will go through menopause later? Oh, that's a very good question. So in general, because you do have a higher ovarian reserve with PCOS, then the chances of going through an earlier menopause is much, much lower, and menopause will tend to be a little bit later as well. Do I need to start trying for a baby earlier? No, I don't think that needs to be a key consideration when starting your family. I think you just have to be mindful when you start trying. Am I ovulating or am I not ovulating? If you are ovulating, then there's no real need to seek earlier help. But if you're not ovulating, there's probably really not worth trying for a baby naturally unless you're certain that you're ovulating and that everything's working nicely. So probably it would make me seek help a little bit sooner from a specialist to help you with ovulation and help you get pregnant naturally, but it wouldn't necessarily change the timing of that. Another question I have: PCOS and currently pregnant after a year of trying to conceive and taking ovulation induction tablets. Are my periods likely to still be irregular once I've given birth? And what is the likelihood of falling pregnant again without more medication? Very hard to tell without knowing a bit more about your situation. However, generally PCOS isn't something that can be cured easily, where the one method of curing PCOS or making the symptoms go away is weight loss. So I think if you found that you had lost, as Nicole mentioned, you can lose somewhere between 3 and 5 kilos and notice that your periods return and that ovulation recurs. Unless that's happened, I think it would probably be a fairly similar situation. So I think probably the need for ovulation induction treatment is probably still there. Although what I do say to a lot of patients is, if you're thinking that you might like to have a baby after 12 months or 15 months or 18 months, maybe you just come off all your contraception 3 or 4 months earlier, see what happens in terms of trying naturally, and then if it hasn't happened, then seek the same treatment that got you pregnant in the first place at that point. So I think we'll call an end to the evening. Thank you very much for attending. Thank you for. We hope you got something out of it and that you learnt a little bit about PCO, a little bit about PCOS, and above all, got some hope that having a baby is definitely achievable, and that helps you in the future. We do apologise. We did have a few technical issues. You'd think after a year of using Zoom, we'd have ironed them all out, but it's thrown a few curveballs at us tonight. We will get the presentation up onto YouTube as soon as possible with that in mind. But if there's anything you missed during the presentation that you'd like to ask, that you'd like to know about, please just email us, hello@newlifeivf.com.au, and we will get straight back to you with an answer. Similarly, if you do feel that you need treatment from a fertility specialist, you can make appointments to see Nicole or myself or any other than Newlife specialists through our website, newlifeivf.com.au, and look for the appointment schedule. Now, the next webinar is next month on Tuesday, 6th of April. So we're trying to run them on the first Tuesday of every month. And again, it will be at 6:30 p.m. We've got some really good speakers next time. And that's Associate Professor Martin Healy, Dr. Hugo Fernandez, and they're going to be talking about fertility and endometriosis together with adenomyosis, and they're both great fertility specialists with a particular interest in those conditions, and they will give a great presentation, I am sure. If you have registered for tonight's webinar, which clearly you have because you're here, you will be automatically registered for the next one, so you will get links to join that, and so that you're reminded. And that's all we have for you this evening. We've eaten into maths, which I'm sorry, but trust me, Nicole's even more upset about that. She's trying to get out the door to maths, so we're going to leave you to it. And we'll see you next month. Bye.